So in terms of patients with chronic kidney disease, I mean, the biggest concern for these patients is the concept of renalism. So renalism is failure to do diagnostic and therapeutic procedures just because you're worried that their kidney function is going to get worse. So let's focus on what we can do from an interventional perspective. How can we safely do coronary angiography and intervention in these patients? So there have been a number of strategies that have been tested to reduce the risk of AKI. I kind of have summarized here as to the time-tested ways of reducing AKI. Of all the things that have been tested, one is to reduce contrast volume, and second is to adequately hydrate these patients. And here you can see that I have arrow marks pointing to each other. So if you can hydrate the patient, you can be slightly more generous with your contrast, but if you cannot hydrate patients, you have to be more stringent with contrast volumes. So in terms of association of AKI with contrast volume, this is data from 1.3 million patients who underwent PCI from the CAT PCI registry. And as we can see here, with the increasing contrast volume, there is a higher incidence of AKI. And of course, there are issues with this. And of course, I mean, now it's more appropriate to say it's contrast associated because we're not sure how much of it is actually induced by contrast. One thing to note here is today we are going to talk about zero contrast PCI, but here the x-axis, here it starts from a contrast volume of 100 to 150, so there is no zero contrast here on the scale. So in this particular study, every increment of 75 ml of contrast used increased the risk of AKI by 42%. So moving to the other part of the equation, hydration. A number of trials, the one I use is the Poseidon protocol. In the Poseidon trial, they used this protocol pre-procedure, 3 ml per kilo bolus of hydration. In the lab, you do an LVEDP guided hydration strategy, and at post-procedure continue the same rate. So a few years ago, I did this experiment with my fellows. So any patient who had a AKI, CKD were referred for cardiac cath. I asked them, what do you think is the volume status on these patients? And invariably, most of them would say, oh, their volume status is they're likely volume up because they're seeing some peripheral edema, etc. But when you do an EDP, you would be surprised because of the NPO for all of these patients, their EDP will be very low at the time of the procedure. So I think this kind of emphasizes that it's really important to measure EDP on these patients to get a better sense of their volume status because physical examination can be potentially misleading. But anyway, going back to this Poseidon trial, close to 400 patients randomized to LVEDP guided hydration versus control. And clearly with an LVEDP guided approach, you give greater volume. So here, if you look at the medium volume, it was twice that of control strategy. And if you look at the primary endpoint, significant 59% reduction in AKI with an LVEDP guided approach compared to control. And if you look at the 6 months major adverse event, significant reduction in deaths, significant reduction in MI, and also numerically lower rate of dialysis with an LVEDP guided approach when compared to control. So let's see one of the examples. So this is a 58-year-old male with CKD5, stage 5, multiple risk factors. He had CKD stage 5 from nephrotoxic HIV meds and diabetes. He was not on hemodialysis. He presented for renal transplant evaluation. He had dyspnea on exertion, no chest pain. He had an abnormal SPECT. His creatinine was 7.5. He gave a GFR of around 7. His EF was normal. His weight is 70. So in terms of the first step, as shown here, a recommendation by the ESC guidelines, one is to assess his AKI risk. Of course, there are a number of risk scores. One of the popular ones is the Maron risk score. Important to note that contrast media volume, and there are factors such as hypotension, intra-aortic balloon pump use, patients in heart failure which carry a very high risk of AKI. So we can use this for this particular patient. When you plug it all in here, you see that this particular patient risk of CIN is 26%, 1% risk of dialysis. So step 2 for this particular patient is hydration. So we did pre-procedural hydration. So the reason I'm showing these numbers are there is a tendency to say, oh, let's give him 100 cc's bolus fluid before the procedure. But if you follow the Poseidon protocol, so it's 3 ml per kg bolus 1 hour prior to the procedure, translates to around 210 ml of saline. Interprocedurally, we measured an EDP on this particular patient, and his EDP was around 12. So we increased the hydration to around 5 ml per kg per hour. That translates to around 350 ml per hour of saline. And post-procedure, we continued the same hydration for around 4 hours. The next step is to do an ultra-low volume contrast diagnostic procedure. So what I typically do is I tend to go distal radial on these patients. So this is accessed through the anatomic snuff box. And one of the main reasons I do distal radial, I also use a short sheath, is to prevent damage to the proximal radial artery as much as possible, because most of these patients will need multiple access sites for dialysis. So it's better to preserve as much of their access site as possible. So I go distal on these patients. In terms of radial versus femoral, observational studies clearly suggest that there is not only reduced bleeding with radial procedures, but also reduced risk of AKI and need for dialysis with radial when compared to femoral procedure. Part of the reason why radial could be associated with the reduced AKI and dialysis could be what we see. This is a cross-section of the ascending aorta, aortic arch, and descending. So clearly you see that descending aorta has a lot of atheroma. Ascending aorta is free of, there isn't much of atheromatous plaque here. So if you go the femoral route, there is a risk of cholesterol emboli and risk of AKI. So we do a low volume contrast diagnostic the catheter engagement. Most of the times I've seen a lot of people use 15, 20 cc's just to confirm that they're actually engaged. Instead of using contrast, we inject saline. So once you inject saline, you see these EKG changes. So these EKG changes indicate that your catheter is engaged. And in terms of the contrast volume for limits for heart stop, there are a number of formulas. The things that I typically use is either 1 or 2 times GFR. If I can hydrate my patients, I use 2 times GFR. If I cannot hydrate my patients, I stop at 1 time GFR. So going back to this particular patient, the GFR was 7. So the absolute contrast threshold is 7 ml if you cannot hydrate. But in this particular patient, we could hydrate, so we can go up to 14 ml. So we take 2 pictures of the left. So here you can see the oreocranial and an AP caudal view using 5 cc's of contrast each. And if you use a universal catheter, which I typically tend to use from a radial approach, this is a Jackie catheter. So we can get the one shot of the RCA with 2 ml of contrast. But if you're exchanging, it's important to make sure we draw contrast from the catheter, because there is at least 3 cc's of contrast in those catheters. So if you're exchanging without pulling the contrast back, you're you're flushing all those contrast into the body. So in this particular patient, we used 12 cc's of contrast. This patient received 1.8 liters of hydration. So we then did a stage 0 contrast PCI. Generally, if it is an elective case, we bring them back 2 to 4 weeks later. So here I have pictures from the 2 weeks prior. So we use this as diagnostic map and then recreate this using a number of wires. So here you see we have a bunch of wires to create a metallic silhouette of this coronary artery. And we are doing an IVUS here. So with IVUS, so in this particular case, we also did an IFR. So many a times I put an IFR or a DFR wire and keep it in the artery. So here the IFR was 0.88. And we do IVUS guided stent sizing, so distal reference, proximal reference. So it gives us stent sizing, stent length, etc. So, and then an LAD intervention was done. So I'll skip through some of these. This is IVUS marking the distal part of the where we need to land. IVUS also marking the proximal marker, deploying a stent, post-dilating, and repeat IVUS, further post-dilating. And this was the summary of the LAD intervention. So IFR pre was 0.88. We deployed a stent. IFR post was 0.95. So in terms of physiology, we kind of fixed this issue. The IVUS was done, showed good stent apposition, no edge dissection. Typically, I ask to see if the patient has any symptoms, any EKG changes, and if the answer is none to any of these, I generally don't inject contrast, so we stop at zero contrast. In this particular case, we went on to do the ramus also. I'll skip in the interest of time, and also we ended up doing the circ, all of which was done with using no contrast at all. So here you can see multivessel intervention, no contrast, IV hydration was given, and the creatinine trends were 8.448 and 7.56. So if anything, the creatinine got better. So I do have a rule for when to take a post-stent angiography. So if a patient has any chest pain, EKG changes, hemodynamic changes, or if I'm using an NC balloon greater than 20 atmospheres, I do take a look. But this, I must say, it's pretty rare. So I would say in less than 5% of cases, I will have to take a final injection. But whenever in doubt, if there is anything that sounds different, it's better to take a quick look to make sure there is no issues. So in summary, as you can see, we can easily and safely do coronary angiography and intervention in patients with CKD. So assess the risk of AKI, adequate pre-procedural hydration, minimize your contrast, and you should be able to do these procedures safely. Thank you for your attention.